Welcome to the Explainer. Today, we're jumping straight into a rapid-fire, high-yield clinical case challenge to test your diagnostic instincts on pediatric orthopedics and trauma. Let's see how sharp your skills really are. To keep things fast and incredibly focused, we're going to tackle these clinical vignettes across 4 thematic rounds: pediatric hip pathologies, congenital hand anomalies, identifying non-accidental injuries, and finally, lower extremity and metabolic defects. All right, round 1, pediatric hip pathologies. Let's dive in. Consider this scenario. A 12-year-old boy with a BMI of 43 presents with an antalgic limp, some thigh tenderness, and a severely limited internal hip rotation. As you weigh the options, the correct diagnosis here is absolutely slipped capital femoral epiphyseus. What you're seeing is a mechanical breakdown right through the vulnerable hypertrophic zone of the proximal femoral growth plate. It classically targets overweight prepubertal and adolescent kids, usually between 11 and 15 years old. The absolute giveaway? That profound restriction of internal rotation. If you grabbed an AP or frog leg lateral radiograph, you'd see the metaphyseal displacement perfectly. Basically, Klein's line completely fails to intersect the outer portion of the femoral head.
Okay, next case. Same region, but a totally different patient profile. We have a 7-year-old boy of normal build presenting with an insidious limp, about half a centimeter of limb shortening, and external rotation. The diagnosis here? Legg-Calvé-Perthes disease. Unlike our last patient, this is an idiopathic avascular necrosis of the proximal femoral capital epiphysis. It characteristically strikes young boys between 4 to 7 years old who are otherwise of completely normal build. And that external rotation you're seeing, it's actually caused by adductor and flexor muscle spasms actively trying to protect the joint. Contrasting these two is a fantastic diagnostic exercise. Slipped capital femoral epiphysis hits heavier adolescents during those rapid growth spurts, presenting with pain that precedes the limp along with that severely limited internal rotation. Legg-Calvé-Perthes, on the flip side, targets early childhood, ages 4 to 7, usually in kids with a normal or shorter stature, and you'll notice an insidious limp that actually shows up before the structural pain does. Sticking with slipped capital femoral epiphysis for just a second, what would you say is its most common and feared complication? Are we talking osteomyelitis, chondrolysis, septic arthritis, or avascular necrosis of the femoral head? If you guessed avascular necrosis, you hit the nail on the head. The retrograde blood supply to the capital epiphysis travels through these incredibly delicate retinacular vessels right along the posterior superior femoral neck. When the physis physically displaces, or if there are high intraoperative pressures during manipulation, those vessels can easily stretch or tear. That completely cuts off the blood supply, leading to a total structural collapse of the femoral head. Now, chondrolysis, which is an acute cartilage necrosis, is for sure another serious complication, but avascular necrosis is unequivocally the most feared. Let's shift gears. Round 2, congenital hand anomalies. If you're looking at a congenitally abnormal angulation of a digit in the horizontal radial-ulnar plane, think radial deviation of the little finger, what are you diagnosing? Is it syndactyly, camptodactyly, polydactyly, clinodactyly, or brachydactyly? The correct answer is clinodactyly, and the absolutely crucial point to remember here is that this horizontal curvature is driven by a structural bone defect called a delta phalanx, basically a trapezoidal or triangular middle phalanx. Just to differentiate, camptodactyly is a fixed flexion deformity in the sagittal plane, usually affecting the PIP joint, and brachydactyly just refers to shortened digits caused by hypoplastic bones. Next question. When programmed cell death fails between the 6th and 8th weeks of embryonic development, it leaves the digits webbed, a condition we know as syndactyly. But which specific web space is affected most often? It's the third web space, right between the middle and ring fingers. In fact, that accounts for roughly 50% of all cases. However, it's really worth noting that the rarest form, the first web space between the thumb and index finger, which sits at just 5% of cases, is functionally the most severe. Because the thumb and index finger have such vastly different lengths and arcs of motion, binding them together severely limits both growth and hand function. That requires early surgical release, very often before the child is even 6 months old. Moving on to round 3, identifying non-accidental injuries. This is a vital shift in tone because recognizing these markers can literally save a child's life. So, which specific fracture patterns carry the highest diagnostic specificity for domestic abuse and non-accidental injury? Sure, simple long bone fractures or horizontal shaft fractures happen every day in routine playground falls. But there are 2 highly specific fracture types that should immediately trigger your child's safeguarding protocols. The first is the bucket handle or corner metaphyseal fracture. This is a stark, unmistakable indicator of violent twisting or pulling forces applied to an infant's extremity. The mechanical force quite literally shears off a small, thin crescent disc of metaphyseal bone right along with the periosteum. If you spot this on a skeletal survey, the mechanism of injury simply does not match a standard fall, period.
The second pattern is the posterior rib fracture. This happens when an adult violently grabs and squeezes an infant's chest from behind. That crushing force bends the ribs over the rigid transverse processes of the thoracic vertebrae, causing them to fracture right near the spine. Recognizing either of these patterns makes it an immediate clinical priority to admit the child and notify protective services.
Let's transition to our final segment, round 4, lower extremity and metabolic defects.
A child diagnosed with bilateral developmental dysplasia of the hip, or DDH, will classically present with which finding? Would it be short stature, an inability to squat, a waddling gait, or a total inability to walk?
They're going to present with a waddling gait, and the reason is fascinating. The bilateral instability completely disrupts the normal lever arm function of the gluteal muscles on both sides, which forces the child to constantly shift their torso side to side just to maintain balance. Now, ideally, we catch this way earlier, using a progressive screening pathway. We start with the Barlow and Artolani clinical screens right at birth. If the hips remain unstable at 6 weeks, we escalate to dynamic ultrasound and utilize a pelvic harness positioning device. And remember, standard pelvic radiographs are essentially useless until after 4 to 5 months of age, once that secondary ossification center finally begins to calcify.
For our penultimate case, let's look at congenital Talipes equinovarus, commonly known as Clubfoot. This condition features structural deformities in how many geometric planes? 1, 2, 3, or 4? The correct answer is 3 distinct planes. It's a complex congenital deformity because it simultaneously involves structural malalignments of the hindfoot, the midfoot, and the forefoot all at once. You can easily visualize these multiplanar mechanics using the CAV acronym. C is for cavus, meaning a high midfoot arch. A is for adduction, where the forefoot actively turns inward toward the midline. V is for varus, which is an inward inversion of the hindfoot. And E is for equinus, a fixed plantar flexion right at the ankle. This exact acronym is brilliant because it also dictates the very specific sequence used in the gold standard Ponseti casting method. We systematically correct the cavus first, then the adduction and varus together, and finally, we correct the equinus. All right, our final case. A child presents with noticeably bowed legs and X-ray findings showing epithelial widening. What's the underlying metabolic pathology here? Is it increased osteoclastic activity, decreased osteoclastic activity, defective bone mineralization, or defective renal absorption of calcium? It's defective bone mineralization. This is the classic presentation for pediatric rickets, which is typically driven by a vitamin D deficiency that impairs both calcium and phosphorus absorption. That epiphyseal widening you're seeing on the X-ray, that's caused by a massive accumulation of unmineralized hypertrophic chondrocytes right at the growth plate. You'll also likely catch metaphyseal cupping and splaying, or even a rachitic rosary forming on the ribs. This leaves the entire skeleton soft and prone to bowing under everyday mechanical loads. Identifying these subtle metabolic signs early can literally alter a child's entire developmental trajectory. So, considering everything we've covered today, how will you use these clinical pearls to see beyond the obvious on your very next shift?